All right. For the sake of time, I am going to get started. Thank you, everyone, for joining us. As a reminder, there is automated captioning available, and so you can select the closed captioning icon in the meeting control bar, activate, and then we've organized this as a webinar, so you can submit questions in the QA section or the chat. We'll also make sure we have time for questions along the way, and so you can raise your hand and we'll unmute you. So great, and feel free to ask questions as we go along. We had some, Janet said that that's allowed, so great. So thank you all for joining us. If you don't know me, I'm Megan Morse. I am the Disability Equity Collaborative, and this is a webinar that is sponsored by our Guidelines and Standards special interest group. And so I'll get started with our introduction here. So Janet Shouse is going to be speaking today. She is a program coordinator, or the program coordinator for the IDD Toolkit, which is a project out of Vanderbilt Kennedy Center for Excellence in Developmental Disabilities in Nashville, Tennessee. She has served as a hub team member for 2 ECHO autism training programs aimed at improving healthcare for autistic adults, as well as working on a number of other projects at the Vanderbilt Kennedy Center. She has been active in the disability community for many years and has engaged in multiple legislative efforts to improve services for folks in Tennessee with autism and other developmental disabilities. She is a parent of 3 young adults, including a son on the autism spectrum. So thanks, Janet, for joining us. I'll turn it over to you.
Well, thank you very, very much for this opportunity to present today on the IDD Toolkit. This is one of my favorite things to do, and I'm going to start sharing my screen, and you'll see if it works like it's supposed to. And we'll see if I can get in presentation mode. And does that look the way it's supposed to for you all?
It does.
Okay. So first of all, I don't know if you do descriptions, but I'm an older white woman with brown hair going gray. I'm wearing my blue framed computer glasses, and I'm wearing a navy blue and light blue shirt with a blue background that says the Vanderbilt Kennedy Center. So today I'm going to be talking about the IDD Toolkit and ways to enhance healthcare for adults with intellectual and developmental disabilities. For those of you who aren't familiar with the Vanderbilt Kennedy Center, we actually have what we call the 4 pillars of our center. We are an intellectual and developmental disabilities research center. We are a University Center for Excellence in Developmental Disabilities, which is the part I work for. We have a leadership education and neurodevelopmental disabilities program. I'm sure many of you are familiar with the LIND program. And we have the Treatment Research Institute for Autism Spectrum Disorders called Triad, which does a lot of training with our Department of Education and helping teachers and paraprofessionals better serve students with autism and other behavioral disorders. We know that people with intellectual and developmental disabilities have multiple comorbidities. Some of the physical health conditions that they deal with that are much more prevalent are epilepsy, constipation, obesity, gastrointestinal issues. And so they're often seeing medical providers more than a typical individual. We also know that they have additional mental health conditions. And this study showed that schizophrenia, bipolar disorder, anxiety depression were all much more prevalent. In dementia, although the proportion of people with intellectual and developmental disabilities who have dementia is relatively small, it occurs at a much earlier age. And I'm sure many of you know that this is particularly true in Down syndrome. Among those youth and adults with autism who do not have an intellectual disability, suicide is the suicide risk is considerably higher than in those that don't have autism. And so these are all things that create additional health challenges for people with intellectual and developmental disabilities. This may be all old news to you, but many of our individuals have complex or co-occurring medical conditions. For instance, my son has difficulty communicating his symptoms or his history or his pain. He basically does not have, at 30 years old, a functional means of communicating. They may have difficulty understanding the treatment options. My son does. They may present atypically. I have heard families say that their child or adult son or daughter actually had a broken bone that they didn't realize for weeks because of the way that the individual presented. They may have a high tolerance for pain, or they may never have fevers. They may have significant sensory issues that make going to a healthcare appointment very, very stressful. Crowded waiting rooms, bright lights, being poked and prodded, all those things can create issues for folks like my son. And they are much more likely to have experienced trauma, and including medically related trauma. Some additional challenges, actually having access to healthcare, whether it means getting in the building or being able to pay for it, or both. Oftentimes, I think you all are aware, there's inadequate or inappropriate healthcare. Oftentimes, there's little preventive care. Just read a study that actually, I think was maybe out of Sweden, that said the new stool tests, like Cologuard, are actually boosting colon cancer screenings because it's an easier way to be screened, but that in terms of like mammograms and pap smears, that all is much less likely to take place for people with intellectual and developmental disabilities. And unfortunately, we know that there is a clinician bias against people with disabilities. A study from 2021 by Lisa Iazzoni found that many clinicians do not feel like people with disabilities have a good quality of life simply by virtue of the fact that they have disabilities, and many of them don't feel like they are qualified or confident in providing appropriate care. We know that medical research often excludes adults with intellectual and developmental disabilities, and health promotion materials are often inaccessible or written in a language that many people cannot understand. And then the concerns of the clinicians themselves, the practitioners, they may have had little or no training with adults with intellectual and developmental disabilities. And most of us, if we don't feel confident in what we're doing, we don't really want to do it. They may worry about the patient's inability to communicate their pain or symptoms or history. As I mentioned, the clinician bias against people with disabilities, diagnostic overshadowing. And if that's not a phrase that's familiar, that's the idea that, well, the person has autism. Of course, they're going to be banging their head against the wall, when in reality, they may be banging their head against the wall because they have an ear infection or an abscessed tooth. There are concerns about issues of consent. Can this person actually consent to treatment? And if not, do they have a conservator or a substitute decision maker? And that can be difficult to ascertain. Feeling overwhelmed. Many times An appointment with an individual with an intellectual and developmental disability is likely to take more time. And we all know that in our healthcare system, time is essential, and folks are paid. If the standard visit is 15 minutes and this person takes 30 minutes, the clinician has lost money and those reimbursement issues. So that's why we have the IDD Toolkit. It was based on a book that was first published in 2011 called Tools for the Primary Care of People with Developmental Disabilities. This came out of Canada, and it was created by the Developmental Disabilities Primary Care Initiative. We created the initial IDD Toolkit in 2013. We took those tools in that booklet. We were funded by the WITH Foundation, and so that you didn't have to have the booklet to get the tools. And the late Dr. Tom Cheatham, who was at that time Deputy Commissioner of Health Services for the Tennessee Department of Intellectual and Developmental Disabilities, was a part of that Canadian group and primary care initiative that created the consensus guidelines and the tools that came out. And he saw the same need for these tools in America that he'd seen in Canada. And since the toolkit was launched in 2013, folks from 193 countries have accessed it. And in 2023, we worked with Surrey Place in Ontario, Canada, to revise, because they had revised their consensus guidelines and their tools. We revised our tools and launched the new site in April 24. This is the homepage of Surrey Place, which houses the primary care guidelines, the primary care tools of the Developmental Disabilities Primary Care Program now. And if you want to go see the guidelines, this is where they can be found. It's excellent information, but what we learned is oftentimes healthcare clinicians do not always take the time to read the guidelines. And so the tools, I found out, were kind of like Cliff Notes versions. So who can use the IDD Toolkit? We have things for the healthcare clinicians, for mental health providers, for people with disabilities, and family members and support persons. And so this is the home page of the IDD Toolkit, and it can be accessed with this URL. So looking at what's at the toolkit, because we feel like we've got a lot of really good information, but it can be overwhelming. So I'm just trying to give you a taste of what's there. So one of the first things we like to talk about is the Communicate Care tool, which helps folks who aren't accustomed to dealing with people with communication barriers or intellectual disabilities, how to best interact with folks who have intellectual and developmental disabilities. There's a section that talks about decision-making and really promoting the capabilities of the individual to decide on their own if they can. There's a section about informed consent that walks you through what are the things to think about. There's frequently asked questions about whether the individual needs a genetic assessment if they come to you as an adult and don't have genetic testing. When is it important to do that? For those who don't know, there's a little tip sheet on adaptive functioning and communicating and what that looks like if you have someone who has an IQ of such and such. This is kind of what you can expect for those who just don't have much experience with folks with intellectual and developmental disabilities. There's a tool to think about when to have a psychological assessment. So this is the Communicate Care, and the CARE is an acronym for communicating clearly, attentively listening and observing the person, responsibly addressing their concerns during the healthcare visit, and engaging the patient and others as needed. One of the things we hear from people with intellectual and developmental disabilities, particularly those with more communicative concerns, is that oftentimes the clinician will come in and talk to whoever's with the individual. whether it's their direct support professional, whether it's their mom, and they don't really engage with the patient themselves. And lots of folks find that pretty irritating. And then here's the decision-making tool, and it walks you through how to think about whether this person is capable of making a decision or not. And, have you looked at accommodating the person's needs? And always check to be able to find out if the patient is able to understand whether they have options or not. And we really encourage folks not to move too quickly to find for incapacity and seeking a substitute decision maker before assessing whether the patient is actually able to show capacity to make a decision. And we do know that capacity can fluctuate from day to day. So this is the tool itself, and it, as I said, it walks you through the things you need to think about. What kinds of accommodations might be needed? What is their IQ level? And let them know that you're assessing their capacity. Okay. And it goes on and walks you through all the things to think about. We're not necessarily thinking that in each instance you're going to use this in the clinical encounter, but it does help you think about, we'd love for you to, but it helps you think about what to ask and how to think about things and whether the person is actually able to give consent. As I mentioned, capacity is not static, and it's important to document it and then identify if the person has a substitute decision maker. And if they're not available or not named, a physician can get recommendations from the ethics board and with the agreement of a second physician on the need for treatment. Because this is a concern when you're treating somebody who may not be able to give consent. This is the genetic assessment tool, and it just walks you through when to think about a genetic assessment. This is the other side is the psychological assessment and why you might want to do one. We have the adaptive functioning tool, as I mentioned, for those who are not familiar. I will tell you, as the parent of an adult on the autism spectrum, the communication box does not necessarily match the adaptive functioning box for my son. But again, it's kind of a broad tool to let you know if you're not familiar. Then we have some tools for the patient themselves with intellectual and developmental disabilities. There's My Healthcare Visit, My Hospital Form, and About My Health. The My Healthcare Visit is really about what a visit today is, what kind of appointment it is, why I'm there. Is it a routine visit? Is it a problem visit? What are the meds I'm currently taking? And I'm sorry, go back to this. And then later on, it does talk about, what did the doctor say? What do I need to do? Do I need to have any follow-up appointments or any therapy or any medications? Just gives the patient a way to organize his or her thoughts about the appointment and what needs to happen after the visit. Then the hospital form, which really came out of COVID, when we were having to allow folks with IDD to be hospitalized without support or family members, which as a parent was very, very scary to me. This walks you through what are the things that are important to know about the person. Do they have allergies? Do they have a behavior plan? And then important information about their accommodations. I may hurt others if I'm scared or confused or in pain. I may have a hard time staying still. What are my communication needs? And it's an excellent way to think about how does this person best thrive in what is for many of us a scary situation, being in the hospital. The About My Health is more of a overall health passport. And because of our limited time with the toolkit, we did not modify what the folks in Ontario, Canada had created. There are a couple of Ontario-specific things in this form, but it's still very useful to get an overall view of the person's healthcare history. Now, there's a section on physical health. There's a health check tool, which is a very detailed list, kind of an overall preventive care wellness check, and it walks you through a whole lot of information. And then we have what we call Dr. Cheatham's checklist. This was the thing he created sort of from his lived experience. He provided care for more than 30 years to people in a congregate setting in Ontario, Canada. And the things he talked about is if a person is displaying new or concerning behaviors, what are the things you think about first? And he always said, blame the drugs. Look at the drugs the person is taking. Are they constipated? Do they have GERD? Could it be a seizure? And then if you've gone through all those things, do you know if they're having pain? Are they sleeping? Then finally think about, is a psychiatric disorder present? So I'll forgot my little circles show up here. And then we have monitoring charts. This is the health check, and it is a review of body systems, and it has things that are specific to people with intellectual and developmental disabilities to look for. And we also have a section that expands on explanations about why things might be different for a person with IDD than it would for a typical patient. And I highlighted the one about sexual health because we know many times clinicians either don't feel comfortable asking or don't even feel like it's necessary. And these questions get to some of the things that we may have confusion about. We may ask, what does having sex mean to you? Because to them, it may be holding hands and kissing, which is going to lead you to different treatment decisions possibly than if they're actually having sexual intercourse. And it does bring up, do you know about sexually transmitted infections and about getting pregnant? And then we have a whole set of new tools in the latest update on epilepsy, which I think was very needed. And we have a tip sheet on kind of general information and first aid for families and folks who've never had to deal with seizures before. And then a tip sheet specifically for families and support persons. And then we have a whole list of monitoring charts, including a bowel movement chart, pain assessment, sleep monitoring, blood sugar monitoring that families or support persons can fill out to help track and give the clinician more information about what's actually going on. We also have what are called health watch tables. And there are these tables for these genetic syndromes. And again, it's a review of body systems that let you know what are the things that are more prevalent, for instance, in Fragile X, and then what are the recommendations to undertake. And while the overall toolkit is aimed at adults, this also includes children. So if you have questions about, what are some things to be worried about in fetal alcohol spectrum disorder or Prader-Willi, this can walk you through what are things to think about and possible treatment decisions or recommendations. Then we have a whole section on mental and behavioral health. And I think I've got little circles coming here. There's the initial management of behavioral crises. There's identifying symptoms and signs of mental distress. One of my favorite that I feel like is helpful for both clinicians and families and support persons is called the HELP tool, Help with Emotional and Behavioral Concerns. There's a risk assessment tool specifically for people with intellectual and developmental disabilities. There's the crisis prevention and management tool, which is often, that's been one of our most popular tools since 2013 that helps people think about what are some ways we can avoid crises and what can we do if the crisis comes to be. The My Coping tool is specifically for people with intellectual and developmental disabilities. I'll talk a little bit more about that. The antecedent behavior and consequence chart, for anybody involved in behavior analysis, this is like step one. But for many folks, understanding, what is the antecedent, what is the behavior, and what happens afterwards can be very important to track. There's a section on psychotropic medication review and how to do that. As a tool about mental health interventions that may not come as easily to mind to folks because it may be a little different. So identifying symptoms and signs of mental distress in a person with IDD. The first section talks about, is this a trauma or stress related disorder, PTSD, adjustment disorder, whatever. Is it a mood or anxiety or psychotic disorder? Is it a neurodevelopmental disorder, genetic syndrome? And it walks you through, what are the diagnostic considerations? What are possible interventions? And then this is the help tool that I mentioned. And one of the first things we encourage folks to think about, particularly if someone is presenting with a new or concerning behavior, is this a health issue? Do they have dental issues? Do they have gastrointestinal issues? Do they have, a broken bone or a strain in a muscle? Look at their health first. Then if everything seems okay with their health, look at their environment and supports. Do they have enough support to do the things they want to do? And in many instances, folks who rely on Medicaid waivers are hard pressed to get the kinds of support they need. Or do they have too much support? Sometimes people chafe at having somebody with them all the time. And then look at their lived experience. And because, as I said, we know that trauma is much more common in these folks' lives. And are there things that trigger them from their lived experience? And then finally, look at psychotic or psychiatric disorders. And again, you're going to have to look at a modified diagnostic criteria, but still, we know that mental health disorders are much more prevalent in this population and they can't be discounted because treating them can be super helpful. So this walks you through the help tool. What are the concerning behaviors? Identify a date when the person was last doing well, what has been tried, what are some of their impairment in communication needs? Do they have a specific diagnosis? Do they have hypersensitivities, hyposensitivities, and so on? And then this is an example of the crisis prevention and management plan. And as I said, this has been very, very popular. Then we have the risk assessment tool for someone in crisis, and it looks at suicide, self-harm, or self-injurious behavior, self-care and neglect. And it goes on to talk about aggression and property destruction. And the mental health interventions are looking at what are the causes, but also what are some things we can do instead. And that may be something as simple as suggesting a next chapter book club or going to a rec center to work out, things that we don't necessarily think about being mental health interventions, but for folks with IDD can do a lot in terms of helping their overall well-being. And then on the right-hand side is My Coping tool. And this is the one specifically for the patients themselves. What about me is happening when I'm feeling good? What are the things I like to do, the people I like to see? And then what are the things that make me stressed or angry or upset? Then what happens when I start to feel more stress? What happens when I start to feel out of control or in crisis? And then what can I do to get myself back to a baseline of feeling good? And we do have a whole section focused on the patient tools themselves. And then we have a whole list of resources. And I will say this, while there are a lot of resources there, I personally vet the resources listed here, and I feel like the things that are listed here are helpful. So, like I said, it looks pretty overwhelming in terms of what all's there. But if you scan through it, one of the things I like to highlight is the booklets that have been created by the Vanderbilt Kennedy Center LEND program. We have a Healthy Bodies thing for girls and a Healthy Body thing booklet for boys. And, it's targeted to preteens and teens, and it's really well written in plain language and with visual supports. But all of this information is aimed at helping you serve this population. And then a couple of other helpful resources. And I realized I used the word providers. And I will say this, I am reading now that clinicians may not be all that excited about the term providers. So maybe I need to go back in and change that. I've read recently that seems to be more of an insurance term. And so I may go in and change that slide. One of the groups that I am very enthusiastic about, and I am a part of, is called the American Academy of Developmental Medicine and Dentistry. And it includes physicians, nurse practitioners, dentists, dental students, medical students, but it also includes family members and self-advocates. And they really have what I feel like is an excellent conference. It's held every June, the first Thursday and Friday in June. And it is my favorite conference to go to. So I highly recommend those folks. They are really doing the work of trying to improve healthcare for folks with intellectual and developmental disabilities, both from a medicine standpoint and a dental standpoint. And then if you're not familiar with the National Association for the Dually Diagnosed, which is not the name they use anymore, they call themselves just the NAD. And I will tell you, if you just look up NAD and not the NAD, you will find the National Association of Diving Dogs. So you want to look up the NAD, but it's an association for people with intellectual and developmental disabilities and mental health needs, and they have lots of resources and trainings, and it is that intersection because so much of the time the mental health world kind of says, we don't know what to do with you folks because they have a lack of communicative skills, sometimes a lack of insight into their own mental health and well-being. And this is a group that really aims at that intersection. And this is the young man who fuels the work that I do. This is Evan and his dad on a beanbag in a giant beanbag because both my husband and my son are 6 feet tall or taller, in his apartment near our home where he lives with 24/7 support through our state's Medicaid waiver. And I have this little QR code, which I'm told lots and lots of people like QR codes. It's I think a 3-question survey, and it tells our funders, which is the Administration on Community Living, that I'm doing something worthwhile. So if anybody is willing to do that, that would be super. So how am I doing on time?
You're doing great. We have plenty of time for conversation and questions. So thank you first going through what a comprehensive resource, lots of materials there. It's great and demonstrates a lot of work. So the first question, well, I'll just add also Peggy Ellerson says, beautiful, inspiring presentation. Very grateful to be a part of this community. So great. Thanks, Peggy. And then Bobby had a question. How can we get access to the extra resources?
Just click on the resource tab at the top of the page, the home page. And now some of them are books you're going to have to buy, but many of them are things that you can simply access on the internet.
Thanks.
And I'm going to put my email address in here in case. I am always happy to talk to folks. If if it's a family member struggling with an issue for their own loved one, if it's a clinician who wants additional information or resources, um, I I help families navigate things like supports and services through their Medicaid waivers, although I am not deeply entrenched in waivers in other states. Know lots about Tennessee's waivers, but I'm happy to help. And I am a connector. I have lots of contacts in other places, and I'm happy to connect folks. But if anybody's got any questions or concerns and they want to reach out to me personally, the Kennedy Center is gracious enough, even though some of this stuff doesn't actually fall within the purview of the IDD Toolkit, I get to help because we want to be a resource and provide information and technical assistance to folks across the country.
Thanks. There's a question. Do you have any tips for looking for PCPs, primary care providers that are comfortable working with people with IDD?
Well, that's an excellent question. I would say if you can find someone who is either a family medicine physician or a med peds provider. For those of you who don't know, med peds are folks who have trained both as a pediatrician and as an internist or internal medicine doctor. So they will have gotten some of the developmental disability training that pediatricians have. And then they also understand adult diseases. Word of mouth is probably the best way if you are connected to some organization like your ARC chapter or an autism organization, finding out who other folks use. I will tell you, I have been in meetings in which people will say, well, we need a list. Can you give us a list of clinicians who do this work and who are happy to do it? Most of the time, they don't want to be on a list because it's sort of a, if you build it, they will come. And while they may be happy to serve some folks, and primarily it's a reimbursement issue. Many of our folks rely on Medicaid, and Medicaid doesn't really cover the costs of care for most of our folks. Even someone like my son who doesn't have a lot of medical issues, still he takes more time. But yeah, connecting with family members who do this, being a part of AADMD, it's a way to connect with folks who are interested. Oh, I see. I'm actually with an ARC chapter. Another place to look is Special Olympics does what they call MedFest. So when they have a competition, primarily when they have their state games, but I think other times too, they actually have volunteer like physical therapists, physicians, nurse practitioners who come and assess the athletes for their overall health and well-being. And so you may be able to connect with a provider through Special Olympics. Also, just a shout out, Special Olympics does have a whole section called Inclusive Health, which is all about providing services to people with intellectual and developmental disabilities. So you can go to their website. If you search for Special Olympics and Inclusive Health, they have online training, which I think is listed in my resources. The Toolkit's resource, not my resource. The Toolkit's resources. I'm trying to think if there's any other ways. I mean, if you in our state, we have 3 managed care organizations that provide services to our what are called TennCare recipients. I will tell you honestly that trying to find a knowledgeable provider through our managed care organization is sometimes finding a needle in a haystack. I do a lot of calling and vetting. We had to change doctors for my son. 3 years ago, one of our managed care organizations created a specialized clinic for people with intellectual and developmental disabilities, specifically 13 and up. And it was wonderful. It was small, but they had a dedicated team. They had they had a psychiatrist, a couple of primary care providers, some nurse practitioners, ABA providers, speech therapists, OTs, PTs, and it was wonderful for 2 years. And then funding got pulled and they closed last August. And so we were forced to find a new provider, and I just sort of had to pick one out of a hat, so to speak. And she was okay. She was very agreeable for one of the reasons that we find very challenging. Everything that Evan takes, whether it's cold sore medication, whether it's ibuprofen, has to be on his medication administration record, and it has to be prescribed by a doctor. And so helping clinicians understand that, yes, you've got to prescribe ibuprofen or Neosporin in order for him to be able to have that administered can be sometimes difficult. And she was willing to do that. Well, I went in to file some paperwork with her in early May and found out she'd left the Thursday before. And they hadn't mentioned that yet. So then had to find a new provider. And it's stressful and time consuming. But I wish there was a good way to find these folks. And there are a lot of people who are doing good work and who are passionate about it. And particularly if for folks with Down syndrome, there are Down syndrome clinics, and a few places have IDD clinics. I just found out about one in South Carolina that is broadly IDD, and they have several primary care providers. But you've got to search. And once you find them, you don't want to let them go. Any other questions?
There's no other, yeah, just open it up for other questions folks have, and I'll just echo, yeah, it is a challenge finding. And yeah, I have thought about one of these days we need to make a directory and across the country, because yeah, there are these clinics that are kind of specially clinics out there that are helpful, and yeah, clinicians.
And then you just sometimes find somebody who's passionate about it. We found a doctor out in Kansas who is basically doing great work all by herself.
Yeah. Oh, it looks like Teresa put in Jefferson.
Is this
looks like
in Pennsylvania?
Oh, they have a complex care clinic. Yes.
Yeah.
So, yeah.
They have been involved with us on some of our echoes. And they do have specialized clinics. Some states have a really, I hesitate to say robust, but they have a lot more options than other places. And so that's great that the Cancer Network has this for LGBTQIA+ patients.
Yeah.
like I said, we just, or at least I personally have found that even when you find somebody who's really passionate about that, they often are reluctant to be a part of a list. Um,
Yeah.
they want to do what's right by their patients, and the idea that they would be inundated might mean that they couldn't provide the level of care that they want to. Um,
Yeah.
so
Yeah. Yeah. I think that is, I've heard that too about health systems of like, yes, if we become accessible and we advertise this, um, then then yes, we're gonna have a lot more patients and they're kind of perceived as expensive. But
yeah,
um,
for example,
yeah.
Rush University Hospital has a
Hmm.
whole page about disability inclusive care, and patients can sign in and list their accommodation needs
Hmm.
and find a provider that is knowledgeable and willing to work with them.
Yeah.
Um, and I'm sure there are other places. It again, it a lot of it has to do with just the the people who've reached out to me and asked me to be on their advisory boards or to come speak to them. Um, I'm a part of a group called the Institute for Exceptional Care, which
Hmm.
is trying to improve healthcare for adults with intellectual and developmental disabilities. They have created what they call a national roadmap to make this work, and they included like insurance payers and Medicaid folks. Um, and but it's incremental work, and if all else fails, asking a physician to at least look at the IDD toolkit or
Hmm.
printing out a health watch table if your loved one, for instance, has Fragile X. Um, I know that takes some courage to take something like that into your physician and say, look, you need to read this.
Hmm.
Um, but but sometimes you can find an open heart and an open mind to uh, to be willing to look at this
Yeah.
information and incorporate it. And a lot of times, you know, the people we find who are willing to do this work, often, not always, but often, we know it comes from personal encounters, whether it's they have a child on the spectrum, whether they had an aunt with Down syndrome, or the kid across the street that they played with had CP. They've they've seen, it's that proximity. They've seen people with disabilities as real loved people in their lives, and they want better health care for them. And some people just do it out of the goodness of their heart, like you, Megan.
Well, no, it's personal for me too.
Oh,
Yes, yes, it is personal for many of us who get into this because
um,
we see the challenges firsthand. We do have a question. So also I just want to, finish out. Yes, there are kind of lots of, again, specialty clinics. The Society for General Internal Medicine has they also have like a working group that is a great network of clinics as well. But there are some specialty, but it's hard because again, they book out for a long time. So there was a question about, thank you for these resources. Appreciate the decision-making resources and how the organization, how organized the resources are. Was wondering if you got a sense of the people who are using the toolkit in their roles.
honestly, we don't track that.
Mm-hmm.
Um, that's something that lots of folks have been interested in finding out. And we do have like a little feedback survey that's
Mm-hmm.
like 3 or 4 questions, but very few people take the time to fill that out.
Yeah.
Um, we we do know that we did focus groups last fall. We're trying to boost the use of the toolkit. We feel like we've got really good tools, but just a lot of people don't know about it. And so we did focus groups with clinicians, with family members, and with self-advocates. And while there were a number of clinicians that were aware of it, very few family members were aware of it. But we think that a lot of times it's found by people searching on the internet. So no, we don't have a good sense of how many folks, what percentage are clinicians, what percentage are family members, or self-advocates, or direct support professionals using it. So anyway, I see somebody is from Rush. My connection to Rush is through a woman named Sarah Ailey, who is a nurse at Rush, and she led an IDD equity project, and she's now working on a diagnostic overshadowing project. And they have worked with the Golisano Foundation out of, I believe, New York, and the, I want to say it's the Fisher School of Medicine, maybe, at Rochester. So yeah, she's doing a lot of work, primarily pre-working folks. So folks who are still in nursing school, medical school, you know, OT, is it OT school? I don't know.
Yeah.
Folks who are studying to be OTs when they grow up. And much of the work that I mean, we would love for the IDD toolkit to be used, you know, in training for residents and nursing schools. And I do a presentation at the Vanderbilt Nursing School every year to about 200 early nursing students, talking about the toolkit. But our aim is primarily for those who are already practicing, who haven't had the training. For those of you who don't know, AADMD has what they call the Niche Med program. And it's a grant program. There is not a particular curriculum, but if a school is interested, if a medical school is interested in providing this kind of training, they have given out grants to, I think it's now 50 schools. And yay, Vanderbilt University School of Medicine just became a Niche Med grantee this year. So I'm tickled to death about that. And so again, if you're looking for folks who have training, maybe looking at those schools and seeing, you can find it on AADMD's website under Niche Med. There's also Niche Dental, which gives grants to dental school. And while yes, it's NICHE-MED. Oh, looks like Eve already put it in there. You're a very useful engine, Eve. Thank you. For those of you who don't know, that's a Thomas the Tank Engine reference. I had a Thomas fan in my house for a long time. Yeah, one of the things, in case you folks don't know, dental needs are a huge issue for this population. Maybe even more so than healthcare, because many dentists do not want to work with our population, in part because you can get bit. If you've got somebody who doesn't understand why somebody else has their fingers in their mouth, and unfortunately, often our folks end up getting sedated in order to get dental work done. One of the things I was very happy to hear when we had the specialized clinic called Kramer Davis Health here in Nashville, they had figured out using behavior analysis how to get all of the dental patients that they were seeing to be able to tolerate dental work without sedation, just by using, you know, bringing them in, getting them accustomed to sitting in the chair, maybe wearing the lead apron, not necessarily just for dental x-rays, but for the work that they were doing. And they actually did a presentation a couple of years ago at AAD&D about how to use behavioral techniques to avoid the use of sedation in dental work. So, and they have, AAD&D does have regular webinars, both for healthcare, physical healthcare, and for dental care. So, and you do not have to be a member of AAD&D to sign up and get those notices. They call them virtual grand rounds. And I think they're like the second or third Tuesday evening. In the evening, it's like 7 o'clock Central Time. But I have talked on and on.
Yeah.
Any final questions or concerns? Again, I'm happy to talk to anybody about any of this stuff.
Well, thank you, Janet, again for presenting the toolkit and great work. And I believe her contact information is in the chat. So if you have any further questions, thanks for
I
reaching
really
out.
appreciate it.
Yeah, absolutely. And I'll just give one plug again to our conversation about health systems, who is doing this work, is we will be on the Disability Equity Collaborative deck. We will be doing October 1st and 2nd. Registration opens up in the next week or so, a workshop, and we'll be having 19 different speakers from health systems across the country, really presenting what they are working on for advancing accessible care. So stay tuned.
Can I give a shout out to your
Yeah.
implementation guide? I mean, when I
Yes.
first saw it, I thought, oh, this is huge. Oh no, but it is so detailed and brings to bear the real lived experience of what's necessary to bring about change at a healthcare system. So kudos to you all who did that. It is excellent. I'm pushing it where I
Thank
can.
you. Thank you.
Thank
Yes,
you so much.
folks on this call, we're a part of that effort. So thank you all. All right. All right. Have a great day.